I'm the nutrition manager at the Greater Boston Food Bank, which I'll refer to on slides and in person as GBFB because it can be a mouthful to say repeatedly. I'm also one of the 2 dietitians at the food bank, and I'm happy to see some of our agencies, our distribution partners. I saw a few online as they were introducing themselves, and I know there are some here as well. So great, let's get started. This is my disclosure. Spoiler alert, no conflicts of interest. So I'll skip to the next. So in my presentation, I'll be giving a brief overview of food insecurity, some basics about GBFB, such as how we work, our food acquisition, and our service area. I'll also be talking about switching the narrative from food security to nutrition security and what that means. I'll talk about SNAP outreach at GBFB, and also some action steps, some suggestions to take away, and how to continue this work. So as you may be familiar with, we are such a prosperous country, as well as the state of Massachusetts is very prosperous itself. However, hunger is here, and it's found all throughout the Commonwealth of Massachusetts. And our annual report finds that 1 in 3 households, or 1 in 3 individuals, have experienced food insecurity just last year. And we've also found this number from years prior as well. So 1 in 3 people are experiencing some sort of food insecurity. And the populations that are listed here have even higher rates of food insecurity. So it's here, as we may have all of these resources, there are still folks that are struggling to find their next meal. And food insecurity, as you may be familiar with, is defined as not knowing where your next meal is coming from, or not having consistent access to healthier foods to live an active, healthy life. An example here, there may be 2 parents that are working full-time and earning minimum wage, so making a total of a little over $62,000 a year. But as you can see in Suffolk County, that $62,000 doesn't even meet half of what is needed to be earned in order to meet basic needs, such as paying for utilities, paying for housing, paying for food, etc. Basic needs, over $163,000 a year must be earned, and those that are working at a minimum wage rate are not even making half of that. So you can imagine some of the sacrifices that need to be made in order to meet the basic needs. Some of these sacrifices are making really difficult choices. Are they going to eat, or are they going to pay for their utilities, pay for rent or mortgage, some sort of housing, medical care, which is more prominent for this group here, transportation as well, education, and so on. This is not just the only choices here. There may be many more that folks are dealing with on a day-to-day basis. As well as the cost of a meal, Massachusetts is one of the most expensive states in terms of meal costs. And more specifically in Eastern Massachusetts, you can see here that it's even more expensive. So not only does it cost $4 a meal in all of Massachusetts, but more specifically in this area, it's even more expensive. And a quote here is from a mother and food pantry user in Boston that they find that food prices have skyrocketed recently. And we also may have noticed that ourselves when we go shopping. And that was one factor that led their family to go to a food pantry. How does this all connect to health? So food insecurity has been linked to poorer diet, lower overall health, and poorer control of chronic conditions. So those that are experiencing food insecurity have an increased risk of these chronic health conditions, such as type 2 diabetes, heart disease, hypertension, as well as an increased risk of having a combination of health conditions, so more than one health condition. And food insecurity can negatively influence diabetes prevention and management through these mechanisms that are listed here. So I'll go through each one by one to kind of explain a little bit more. So as I've mentioned, there's an increased diabetes risk if someone does not have diabetes already and they are food insecure. As you can imagine, potential poor diet quality where folks experiencing food insecurity may be reaching or purchasing less expensive foods that are very nutrient dense. And I'll talk a little bit more about that a little bit later on. Competing demands, as I've mentioned, there's a lot of decisions that need to be made. Am I going to eat healthy or am I going to eat this meal that's less expensive? Am I going to feed my children or am I going to feed myself? Am I going to buy the medicine that I need or am I going to eat? So on and so forth. Poor mental health. You can imagine how stressful it is for someone experiencing food insecurity. And poor mental health can also exacerbate all of these other prevention and management mechanisms. As mentioned, with competing demands, this also goes into reduced diabetes self-management. So folks that are experiencing food insecurity are less likely to manage their diabetes themselves. They're making all of these tough decisions and opting for something other than their medication, checking their blood sugars, so on and so forth, being able to attend doctor's appointments and receive all of the resources needed to manage their diabetes. As well as this kind of plays into poor glycemic control. Those that are experiencing food insecurity tend to have higher rates of HbA1c levels, even if, and studies have found that even if their diet quality is a little bit better, they still, if they're experiencing food insecurity, their HbA1c levels are still higher. Greater healthcare expenditures. So folks experiencing food insecurity may be visiting the ER more and having more doctor's visits and so on and so forth, or choosing if they can even afford to go to the doctor. And absenteeism. So absenteeism is they're more likely to miss work for whatever reason, which then leads to less money being made potentially, which then kind of continues this cycle and exacerbates all of these mechanisms. So all in all, to summarize all of this, food insecurity negatively influences diabetes prevention through all of these methods and mechanisms. So it plays a great role in the prevention and the management. So who are we and how do we play a role in this? So this is the Greater Boston Food Bank, if you're not familiar with it. If you are on your way here from the Boston area, you may have driven right past this building. So if you're going I-93 South, you'll see us on the right there. If you're going north, we're on the left. So this is the building here, and this is where we store all of our foods. So millions and millions pounds of food. So large amounts of food, which I'll talk about in just a moment. And our mission is to end hunger here. We are one of the leading emergency providers and one of the largest food banks in the Northeast. So how do we work? So this kind of explains here what a food bank is and what we do, especially since a lot of people use food bank and food pantry interchangeably. It is not the same thing. So a food bank, what we do is we acquire food through various methods, which I'll discuss in just a moment. We sort the food, store it, package it in our 117,000 square foot facility, that giant building that I just showed in that last slide. And then this food is then distributed to our network of over 600 distribution partners. So these are food pantries, meal programs, direct distribution sites, so on and so forth. So that is how folks are able to get the food through us. So if you think of it in more simple terms, we're a food bank. So think of a bank of food. We hold the food. Individuals do not come to us. Individuals are going to our distribution partners. And this is our service area. So our name is the Greater Boston Food Bank. However, we serve all of Eastern Massachusetts. So as you can see here, all the way from the Cape up to Worcester County, and then south to north, bordering New Hampshire. So we serve individuals all throughout this area. And the dots here are food pantries and meal programs. So as you can see, a majority of them are within Boston, but it spreads out throughout our network as well. So where do we get our food? contrary to popular belief, we actually purchase the majority of our food. So 76% of our inventory is purchased through private funding, MFAP, which if you're not familiar what that is the Massachusetts Emergency Food Assistance Program. So we are very, very lucky that in the state of Massachusetts, we have a line item in our budget that is going towards emergency food programs such as food banks. So we get a large chunk of our money through the MFAP program, as well as through the USDA. And then the last quarter here is donated. So retailers, farms, manufacturers, and other mechanisms as well. Think of this as large pallets of food that's being donated, not necessarily individuals that are kind of cleaning out their pantries and are saying, I can donate this. So that we recommend to donating to your local pantry. To us, it's too small of an amount. And then our food is distributed through all of these different partners. So the majority of our partners are pantries at 83%, as well as multi-service, meaning they're a pantry and a meal program, or some kind of combination of our distribution partners. Direct distribution, such as our mobile markets. So we load up a giant truck with food and set it all at a table at a destination, and then folks are able to come in, choose the food items that they'd like, and then move on. So that's our direct distribution, as well as meal programs such as soup kitchens and whatnot, and also community servings is one of our partners. And then a small amount are shelters. This is an example of a food pantry. I like to show this because folks who are not familiar with what a food pantry looks like, they may have the assumption that it is the basement of a church and just some tables with some food distributed on it. And while that may be the case for some pantries, a lot of our pantries look like this. So they look like a mini market. So the picture on the left here is one pantry, and then another pantry is both of these images in the middle and on the right. So as you can see here, they are stocked and clean facility, and looks like a market as you would, and someone can walk in, this is kind of the ideal distribution setup. Someone's able to walk in, choose what they'd like, and then instead of like a regular store where you pay at the end, you just go home. And as you can see here, there's a lot of fresh produce. It's not just canned soups and things like that. Also eggs, milk, so on and so forth, that they're able to distribute in a pantry setting. And like Michael said, a lot of pantries, due to the really high demand that we've seen, especially since COVID, a lot of pantries did have to switch from this distribution model to a drive-through model, quickly packing bags and distributing those, rather than being able to host so many people coming in and being able to shop individually. To give an idea of what this number may look like, I don't believe I had this slide up, but we used to see about 300,000 households visiting pantries, and since COVID, that has doubled. So over 600,000 individuals are visiting a food pantry, and that number has stayed high. It has not gone back down. So now moving on to food security, moving the discussion now to nutrition security and some of the work that I do. So nutrition security is defined as consistent access, availability, and affordability of foods and beverages that promote well-being, prevent disease, and if needed, treat disease. So nutrition security is making sure there's access to nutritious foods, not just foods, where food security is focusing on making sure that everyone has enough to eat. Nutrition security is making sure that everyone has enough to eat and that it's a healthful diet as well. And at the food bank, we have the saying, nutrition matters. And 95% of our food inventory meets our high nutrition standards, which I'll talk about in just a moment. 33% of our inventory is produce. So again, contrary to popular belief, it's not all just like canned soups and cereals and things like that. We do offer a majority of our inventory through produce, as well as lean protein and dairy at almost 30%. So this is SWAP, our nutrition ranking system and our nutrition standards. SWAP stands for Supporting Wellness at Pantries. And I'll go through a little bit on the top right here with this little chart. SWAP looks at three key nutrients, nutrients of concern when it comes to disease, saturated fat, sodium, and added sugars. So this chart here breaks down, this is cut off, of course, it keeps going. There's many different food categories, so that way you're not comparing like meats to apples. They're not the same thing, they have different nutrient components to them. And all the different food categories, and then we use a stoplight system. So choose often is green, and these are foods that are low in saturated fat, sodium, and added sugars. Thank you, Vanessa, I see that comment about SWAP. So green foods, think of fresh produce, lean meats, lean dairy, etc. Choose sometimes are foods that are medium amounts of these three nutrients. So this can be something like white bread, pastas, foods like that. And then red here for choose rarely are the foods that are high levels of the fat, sodium, and added sugars. So these are like your sodium-rich soups, your desserts, snacks, chips, etc. So those typically fall under that category. So what I do in some of my work is I actually rank our inventory using this system. And then the items are color-coded. And then here on the bottom right is a quick little screenshot of what our distribution partners see when they are ordering from us. So they're able to see the different foods that we have in inventory, as well as a quick circle marking of the SWAP ranking. This also helps guide our nutrition policies. So we were one of the first food banks in the country that developed a nutrition policy, and this is what we follow when we're purchasing foods and acquiring foods. So as you can see, the numbers have steadily gone up. During COVID, in the second column there, it may look a little low. That's when we were in an emergency state. Just get the food out there. We need to feed people. Let's not worry too much about nutrition. Our biggest concern is just making sure that everyone is eating. And then it has gone up since then. So 96% of our inventory is ranked green and yellow, meaning that it is of the high nutrition standards. And then this is the amount of produce as well. And the in terms of pounds distributed. As Michael mentioned briefly, we also have our Healthy Pantry program, which I help manage. And this is a kind of teach the teacher type of program where we provide online modules that talk more about SWAP, our Click and Cook as a resource, which I'll talk about in just a moment, as well as nudges, which is a marketing technique. So when you go to the supermarket and you see that there's all those sugary cereals, nice and bright, colorful right there, it makes you want to reach for that. So how can we do that in a pantry setting? How can we nudge people to opt for the healthier option? That's something that we discuss as well as other general nutrition topics, so that way they're able to answer one-off questions. As well as, along with the modules, they have a consultation with myself. So I visit the pantry and I'm able to kind of, with fresh eyes, navigate through the pantry and see what small changes that they can make to help promote the healthier options. And Click and Cook. This is one of our resources that is available for anyone to use. Please feel free to use this resource. This is our recipe website. So you're able to navigate it with by looking up what ingredients you have, and then recipes pop up utilizing those ingredients. So you can also search by a keyword as well. It provides all of our recipes are low-cost ingredients. We try to not have any saffron or really expensive ingredients, as well as easy to follow, easy to cook, relatively easy, of course, and then no special equipment needed. We don't need a mandolin, we don't need all of these other things to create the meal, as well as a nutrition facts label is added onto there, and then our ranking system as well. And this resource helps promote the healthier foods as well, where, as I've mentioned, a lot of pantries, they've had to switch to having to pre-pack a lot of bags. Folks receive those bags and they're like, I have no idea what to use with half of these items. Now, you can go on to Click and Cook and find out what to do with those items. And if you ever have any recipe recommendations, please let me know. I'm happy to set those up on there. We also have a lovely, lovely SNAP outreach team. So this is another way that we're able to help individuals get access to foods and have autonomy over the foods that they are able to choose. So our SNAP outreach team helps with applying for SNAP, as well as recertifying for SNAP, so on and so forth. Someone calls in and we're able to help them navigate through that really confusing, really lengthy application that's really private. And they're able to go through step by step to help them not only receive SNAP, but also receive the most amount of benefits that they're eligible for. As well as outreach and education, where they're able to distribute outreach materials, flyers, so on and so forth. I brought a handful of flyers if you're interested in posting any of these posters up in your offices, if applicable. As well as our contact information, so you can refer your patients to us as well. So how can you contribute to the work that we do, and how can you contribute to nutrition security? This here lists some action steps that I came up with. However, if you're reading through this and you have other suggestions, please let me know. I'd love to share that as well. But looks like for the first bullet point, you've already done part of this. So understanding what a food bank is, what we do, the difference between a food bank and a food pantry, what they do, and how we play a role in nutrition security. Avoiding assumptions about your patients. Not every patient has a full kitchen, or I should say consistent access to healthy options. So rather than telling them what to do, working with them and seeing what they're capable of doing and working through that. I learned that a lot when in my previous job at WIC. When I would counsel families and I would suggest something and they would say, I can't make that, I can't cook that, how can I do that? I only have a microwave, or something along those lines. So getting really creative with your clients and your patients, and not just assuming and telling them what to do, but really working with them about what they can do and navigating through that. And if you're not already doing so, conduct food security screenings. So I know when I go to the doctor, one of the first things that I'm filling out in that bunch of paperwork is a food security screening. So if you're not already offering this, conducting something like this can really start to open the conversation about navigating through that and offering referrals and so on and so forth. So I have under here, use conversation starters when screening. Some folks may not feel comfortable bringing this up because they don't really know what to do or how to help. And that's where these next couple of bullet points can come into play with that. But as well as making it something casual. And some of the research that I found, one healthcare professional, they frame it more as rather than saying like, are you familiar with WIC or anything like that, they would say, oh, a lot of our patients are receiving WIC. Have you signed up already? And just something like that can really open up the conversation and make someone feel more comfortable and not stigmatized to utilizing the resources from that incredible program. As well as, of course, using patient-centered care behaviors to increase comfort. As we have mentioned, cultural sensitivity when navigating through this, really opening the conversation up, providing that comfortable environment so someone can talk about this really uncomfortable topic that is really private and sensitive to them. And then offering referrals to federal nutrition programs such as CSFP, SNAP, WIC. These types of programs can really help individuals in opening up what they're able to have access to, and especially the nutritious foods. So having a quick referral to this can be like, oh, here's the phone number to this program, here's how you can call and get started with that application system. And this kind of goes into the next one of have existing materials readily available that identify resources in the community. So one thing that we had when I worked at WIC, we had a one page that had everything on it that was local to the area. Not just other food assistance programs, but also housing programs, daycare vouchers, so on and so forth that can relieve the stress and help someone when making those really tough decisions that we talked about earlier today. And this opens up also an opportunity to develop a relationship with your local community partner. So offering that relationship and seeing how to work best with each other to then be able to help navigate these conversations and get folks the help that they need. And I know a lot of this can be a time-consuming thing as well. So we are seeing a lot of people, we don't have enough time in our days, but some ways to kind of navigate through the time constraints is to have a basic knowledge yourself of what the programs are, what they do, what the resources are, so you're able to quickly answer and quickly provide that referral or recommendation of what to do, as well as having those existing materials can go a really long way, where you have the one pager and say, highlight really quick, this is where you can find resources of what can help you. So having those things can kind of make things move a lot faster and also get people the help they need. Finally, here I have advocacy, which is more of an individual thing as well. I should probably add here like volunteering at your local pantry and work like that can really help our network as well. But we have on our website a whole page that kind of explains more about federal legislation and also state legislation that we want to advocate for, so folks are still able to receive SNAP WIC. And that we are able to continue to receive the funds to be able to distribute the foods out. And that is all. Thank you so much.
We do have time for questions. So we can do that, and then we can do a panel. So anybody have any questions for Laura?
What was the acronym for CSFP?
CSFP, Commodity Supplemental Food Program. So that's geared more towards seniors. So they're able to receive boxes of foods that our volunteers kind of pack up. And that's through the USDA and whatnot. And there's also nutrition education in those boxes as well.
Thank you.
Yeah, of course.
Has anybody volunteered at a pantry at all?
Great.
Done another thing.
Yeah.
Do you have a contact that I can have, we have somebody at our health center who does, we used to have like a food pantry that run every Friday. I think that they've been having problems with who we used to get food from. So I would like to have some contacts so that I can get them signed up with you so that they can get some.
Yeah, absolutely. I have a card for myself that I can pass around, so that way you can contact me and I can send you in the right direction for that. Yeah. We also, I should probably have had a slide about this. We have a need food page on our website. If you want to utilize that as a resource as well, folks can go online and put in their zip code or where they're located and see the food resources that are closest to them with a lot of information there.
Yeah.
And if there's any questions in the chat, please share.
Yes, Michael, great presentation, excellent. This is Karen D'Antonio from Health Centric Advisors. There's a couple comments in the chat I can share. Vanessa shared that she volunteered at the Greater Boston Food Bank, huge production, very impressive. There's a question, how cultural sensitive are the click and cook recipes, and do diverse people find it helpful, delicious?
Great question. So that's some of the work that I'm actually diving into now and starting out. This has been a huge topic across the network of food banks across the country is cultural responsiveness. So yes, I am working on materials for our network for food guides that have information about the various cultures that are the top cultures within our network that we found through research, able to provide information on that because there are a lot of pantries that may not be of the culture themselves, but they're serving a specific population and they're not really aware of what to order and whatnot or what to have for folks, as well as along with this, adding more cultural recipes to our website in a mindful manner, of course, and how to do so in a very inexpensive way, but as well as in any type of setting. For example, we have a lot of, I've been hearing throughout our network that we have a lot of Haitian families coming in who are in shelters and don't have like a full kitchen. So how are they able to create their traditional dishes and the foods that they like in that type of setting? So that's what we're working on now. So that's in the works. But if there's any suggestions or any resources that could help me in this process, I would be happy to hear of those as well.
Great, thank you so much.
I'm just curious, this year I started to volunteer for a pantry. They're almost like little businesses unto themselves.
Yes.
And so you provide them some guidance, some resources, but through their volunteer leadership, they often kind of take on a life of their own.
Yeah. So we are here to help and we work with them to kind of get other resources as well, other connections. How are we able to increase capacity? So we have a whole team that works with our distribution partners to kind of work through that, navigate that. And also how to form relationships with other sources of food as well. So they're not just receiving food from us, which I wouldn't recommend because God forbid anything happen now that it's affecting them as well. But how else can we connect them with other resources? So we also have a team that connects them with supermarkets. So we cut ourselves out as the middleman and develop that relationship where supermarkets and other large organizations like that are able to distribute and donate food to them as well at low cost, as well as farmers markets, so on and so forth. So kind of working through the resources that we have in our area to help uplift and continue that.
And I know like a lot of Ys got involved during the public health emergency. Are they kind of sustaining? Do they drop off? Seems like the need's still there.
Yeah, the need is definitely still there from a philanthropy standpoint. A lot of folks have kind of backed off since COVID and the emergency state that we were in, and food banks across the country are all experiencing this where it's almost like, okay, the emergency state is over, so everything's fixed, right? And it's not. So working through that and kind of seeing if there's other ways to continue to advocate for this and continue to receive the funds needed to continue this work and upkeep with all of this work. And again, it's millions and millions of pounds of food. And I encourage you all to come visit the food bank as well. I'd love to give a tour and host. I've kind of spat a bunch of numbers to you all, but sometimes that doesn't sit until you actually see it yourself and you're able to see what that looks like and realize that that unfortunately is not enough. Folks still need more and want more.
Casey, do the FQHCs work with pantries? So you have your own pantries often, don't you?
Yeah, so we at the League don't have a pantry, but a lot of the FQs will have a pantry or connected to a pantry, but I'll definitely share this resource with everyone.
Great.
It's super exciting.
Okay, if there are no questions, we'll
Oh,
kind
I
of.
think we have one.
I have one quick question, because I was
Absolutely.
really interested in well, everything you said, but specifically the SNAP program that you run and you support people in obtaining their benefits and anyone can get referred to you. I was just curious, like, where are you getting your referrals and where do you promote that? 'Cause it's really
Yeah.
interesting.
Absolutely. So we promote it on our website, of course, so we have that resource there. We receive referrals from all over, folks. There are constantly individuals reaching out, asking for assistance that we're able to kind of navigate and let the SNAP team know to reach out to them. Our voicemails and our phones are constantly blowing up as well as our emails. As well as a lot of like healthcare partners too. We've done some outreach there too and kind of started to develop that connection there. And through our programs as well, a lot of our distribution partners are providing that resource and whatnot, and themselves also doing SNAP applications. There's a lot of pantries that are offering that service too, and if they're overwhelmed, then they can kind of hand them over to us, vice versa. We worked with the DTA and Project Bread on a lot of these applications too. Yes, yeah.
I'm gonna ask one more question and I'm
Yes.
gonna stop. I think that, you've heard of barbershops where they check blood pressures and it's kind of a community area. I think that pantries may serve that role where we do some education,
Mhm.
some screening, is
Yeah.
that kind of?
So
being
some of
done?
our pantries are able to do that. Some of our pantries hire dietitians, which is really amazing to see. And are able to kind of connect themselves with maybe another organization that's able to get them the resources and that kind of individualized help. And then we also have some pantries through healthcare partners as well. So MGH has a plant-based pantry that it's really easy to kind of like refer someone to say like, oh, step right over here and you can receive some foods. And they're able to, and folks feel less stigmatized to go because their doctor's telling them to do it. And that's something that is kind of like prescribed to them. So we do have some partnerships with some healthcare organizations as well to kind of promote that and kind of mesh the connection.
And I can add, so we're working with DPH the Brockton area learning collaborative around hypertension. So we are looking to see if we can work with the Brockton Area Hunger Network to put BPSMP into pantries, screenings, support through the Y, but we do run a full service pantry. It does get pretty hectic in there with
Yeah.
where full choice, like a market, like with not as
Yeah.
fancy, but kind of jealous, but it's something we're looking into and seeing if we can get other pantries on board. So we'll have to see how that works over the next year. So I'll report back.
It really opens up to innovative care delivery
Yeah.
systems. Well, let's give it up to Laura, that was amazing. As we prepare for our next presenter, I'll just get up, do a moment stretch if you need to, get a drink if you need to, and I'll queue up our next presenter. We're so grateful. You know, you think pantries, but here we are at Community Servings that are really unique in many ways, and you'll find out why. Community Servings was founded in 1990 as a diverse coalition of AIDS activists, faith groups, and community organizations to provide home-delivered meals to individuals living with HIV/AIDS through the leadership of the American Jewish Congress. And that was in 1990, and over the last 35 years has really evolved to what it is today. They have their offices where our next speaker works out of in Jamaica Plain, and we just happen to be in here in Mansfield, where in 2023 they opened up their new facility. They've provided over 10 million meals, and I've had the pleasure and the honor to sort them. And whether people are being treated for cardiovascular disease or chronic kidney disease or whatever it may be, it's really an amazing process. So we're so grateful to have Valerie Machinist with us. She's the Director of Nutrition and Client Services at Community Servings. She's been there for 6 years and has over 20 years of experience as a registered dietitian, nutritionist, and health educator in a variety of corporate and public health settings. Her areas of expertise revolve around management of chronic disease, weight management, sports and exercise nutrition. Prior to joining Community Servings, Valerie was the National Director of Nutrition at Optum, which was a division of United Healthcare Group. She has her master's in nutrition and public health from Columbia University and her bachelor's in nutritional science from Cornell. So we are so grateful to have Valerie with us today. Thank you.
Thank you for being here. Thank you, Laura. That was such a fabulous presentation, and I learned so much about the Greater Boston Food Bank, even though I've been there a lot of times. I am going to talk a little bit about some of the things that Laura talked about today around food insecurity, but I'm going to focus on the idea of food as medicine, which is what Community Servings really focuses on. There we go. Also, no conflicts of interest and nothing to disclose. So I'm going to give a brief overview of Community Servings and who we are, what we do, who we serve, and how we operate. And talk a little bit about medically tailored meals for those of you who are not familiar with what those are or what that concept is. I'm going to discuss the impacts of food insecurity on individuals living with critical and chronic illnesses. Laura did a fabulous job going over that a little bit, so I'm not going to be repetitive about it. And then talk a little bit more about food insecurity and where food as medicine interventions can help support food insecurity initiatives. So community servings, as Michael said, has been around for about 35 years, and we are an agency that provides home-delivered medically tailored meals to individuals living with critical and chronic illnesses. The thing that's notable about community servings for this discussion is that we are historically not a food insecurity program. So that is not what we set out to be, but we fill that gap. And the more and more, especially since COVID, we are really starting to fill that role. And I think we will continue to fill that role in the future as well. This is a snapshot of who we serve. You can see here, it's a little bit hard to see for those in the room, but 100% of our clients are experiencing one or more critical or chronic illnesses. And again, even though we're not considered a food insecurity program, 90% of our clients are living under 200% of the federal poverty level. About 10% are experiencing unstable housing. And while we don't have any age cutoff, as long as you can eat solid food, you can receive our meals. We have clients that are as little as 8 months old, and we have clients that are over 100 years old. So we serve a pretty wide range of individuals. Most are over the age of 45. We serve the entire state of Massachusetts in a variety of ways, which I'll talk more about. We recently expanded into Rhode Island as well, so we can serve pretty much the whole state of Rhode Island, and not expressed in this graphic, we actually serve 3 counties in southern New Hampshire as well. So we have a pretty wide distribution area, and it just keeps growing. Part of the growth, or part of opening this facility here in Mansfield, in addition to our location in Jamaica Plain, was to allow us to expand out farther on the Cape and south to Rhode Island as well, and actually farther out west because of better access. So food as medicine is the intersection of food and healthcare. At least that's how we think of it here. It's food as medicine interventions are the systems in place that can increase access to food that supports health. So we, at Community Servings, we're focused on medically tailored meals. In 2025, we're actually going to expand to provide medically tailored groceries, which I can talk a little bit more about. I think the Greater Boston Food Bank is going to do some of that as well, which is a really exciting space for us to get into. Food as medicine can also be food assistance programs such as SNAP and WIC, and a lot of what Laura talked about with food pantries and food banks, where there's really a dedicated effort to make sure the foods people are choosing are supportive of their health and as healthy as possible. And then also healthy food prescription or healthy food voucher programs. So medically tailored meals are meals that are designed by ideally a registered dietitian nutritionist, or at least approved by a registered dietitian nutritionist, to be supportive of a variety of medical conditions. In the case of Community Servings, we have a really super talented culinary team. They do all of the recipe ideation, but nothing goes out to our clients or into production without someone on our nutrition team saying this meets our standards. And there are a set of national standards as part of something called the Food as Medicine Coalition, which I'll talk a little bit more about, that dictate really what we should be looking for in terms of nutrient cutoffs for our various diets. So for example, we control very carefully for carbohydrates when we're providing meals for individuals with diabetes. For individuals on dialysis, we control very carefully for potassium, phosphorus, sodium, and fluids. So we take different diseases and we really try to make sure the food we're feeding the individuals with those diseases are appropriate and can be helpful and healing for them. We at Community Servings follow the National Food as Medicine Coalition guidelines. We have some of our own internal guidelines that are a little more strict that we follow, but it's not like just kind of a haphazard thing where something looks healthy, we really do analyze and look at every recipe that goes out. Michael mentioned a little bit of this in his introduction, but medically tailored meals are not unique to community servings. There's about 30 agencies across the country right now who provide medically tailored meals in a way similar that community servings does. They were largely developed as a strategy to support people living with HIV and AIDS in the 80s and 90s when there were no medications, no antiretroviral treatments, and really the only thing you could do during that time was feed someone and make sure they felt safe and comforted and were keeping the weight on as best as possible. So many agencies like community servings have their roots from that time. Over time, though, everyone kind of realized that medically tailored meals could support a wider variety of conditions, and as medications became available to support individuals with HIV and AIDS, we were able to expand and support individuals living with other medical conditions. Medically tailored meals are typically fully prepared and home delivered or picked up, so different from a food pantry or medically tailored grocery boxes even, where the food we provide leaves our facility fully prepared and it just needs to be heated up for someone to eat it. I mentioned this, that all of our recipes are evaluated by our registered dietitians, and we again ensure that we are meeting the specific medical needs of the clients receiving the food from us. Like I said, about 30 agencies and growing provide medically tailored meals throughout the United States, and if you're interested in learning more about that, the Food is Medicine Coalition website is a really great resource for so much information, but a lot of policy and advocacy information, but also just if you want to learn more about medically tailored meals and the work we do. Here at Community Servings, we have 16 different medical diets, which I'll show on the next slide what those are. You can see a little bit on the right. This is in fiscal year 24. What we did, we served about 1.2 million meals, which is pretty exciting. And we serve just shy of 7,000 unique individuals, but on any given week, we're providing meals to about 2,400 individual clients. And part of the medically tailored meal intervention also includes support from our team of registered dietitians. So we have a team of 5 dietitians who provide nutrition education for groups, individual counseling, and are just in general there to support the needs of the individuals receiving meals from us. So this is how our medically tailored meals work here at Community Servings. We have what we consider 6 core diets. So they are, for example, our wellness diet, which is for someone who may not have very specific nutrient needs to be supportive of their medical condition, but really need an overall healthy diet. Diabetic, cardiac, renal, pediatric, and newest is we have a diet specifically for individuals with high-risk pregnancies. All of our food is really carefully controlled for sodium and is generally low in fat and extremely healthy, which takes a little bit of getting used to for some of the clients that we serve. But in general, once someone receives meals from us, they start to learn what it means to eat healthfully and what healthy food and nourishing food tastes like, which is really means a lot to all of us here because it means we're doing our job. The way the rest of our program works, though, is we take a core diet, and when one of our dietitians speaks with a client to get them started on our meals, we figure out which core diet they need, and then we can add modifiers to that, either they're medical and preference-based. So we can take, for example, a cardiac diet and make it vegetarian and soft, for example, for someone who has trouble chewing. So you can see the modifiers on the right-hand side there. We are a pork, shellfish, and nut-free facility overall, so that kind of covers some basic allergens. We can tailor for some other allergens, but not everything. So, someone who's coming to us who needs to eat gluten-free because they have celiac disease, we can't necessarily support them, but we can work around a lot of others. Here are just two examples that you can quickly look at, the way we can sort of layer the different diets that we provide individuals based on their medical needs and preferences. So, you know, again, this is where our team of dietitians comes into play, and they work with every client that starts our program and figures out exactly what their needs are. And this just shows really the full medically tailored meal intervention. And this holds true for most agencies providing medically tailored meals. It's not just delivering meals to someone, it's making sure they're getting the right food that's supportive of their health needs, providing nutrition assessments and ongoing counseling, getting the meals to them from our delivery team, making sure that they stay on the meals. So that's actually a whole thing too. Once someone starts our meals, if they're not used to eating the type of food that we provide, it does take some convincing and a lot of skill from our dietitians to really help support our clients to make sure they understand how to eat our food, if they need to season it a little differently, whatever it takes to get them to eat the food so that they can feel better. This is a graphic of what a weekly delivery looks like. So we say that we provide 5 days worth of lunches, dinners, and snacks in a weekly delivery. We only deliver once a week. So a client can expect to get enough to feed them for 5 days. We do not allow clients to choose individual menu items either. So that's where we differ a little bit from some other food providers. We provide a variety of healthy meals. Everyone, unless they have specific preferences in place, they'll get a variety of plant-based and some meat and fish foods, all tailored to meet their needs. But this is what they will get in one delivery. And we deliver both by a community servings driver. We have drivers that leave both this facility and our facility in Jamaica Plain and drive to our clients' houses. And when we can't reach them by delivery, so really like the far western part of the state and also way that like the eastern part of the Cape, so sort of like the tail ends of the state, we can't necessarily get to by delivery driver. We can in some cases ship via UPS. So they'll get food in an insulated box that holds its temperature for about 72 hours. The other thing that we're able to do in many cases here is we can provide food not only for the primary client, but for up to 2 caregivers and any dependents under the age of 18 in the home. And this is a really long-standing philosophy and belief of community servings, is that if you don't feed the whole household, you're not going to solve the problem you're trying to solve for. Because we know that if the primary client is sick and has children in the house, they're going to feed their children before they feed themselves. So in order to make sure individuals are getting the full benefit of the food we provide, when we can, feed caretakers and children under 18 in the home.
Excuse me.
Yes.
What's the criteria for that, really, feeding the whole family?
What's the criteria for
Yeah,
feeding the
you
whole
have to
family?
yeah.
There are certain cases that I will get to where someone is receiving meals from us funded or supported by their insurance provider, and that provider may not also allow for the household to receive meals. We have some ways to work around that occasionally, but that's the only instance where we wouldn't feed the entire family.
Okay.
Which leads me to how the agency gets funded. We have 3 main buckets of how we are supported to do the work that we do here. One is philanthropic dollars, so just straight up donations that come in. Under that bucket of funding, anybody can apply for our meals program. Our application is on our website, and if you medically qualify, we will feed you. So that's another way that community servings differs from some other programs, is that we don't have any financial requirements. It doesn't matter. We don't look at that, but you must medically qualify for our program, and we have sort of a list of internal qualifying factors. You basically have to be at a critical stage of a chronic illness medically qualify. So someone, for example, with significantly uncontrolled diabetes, we usually look at an A1C of 7 or 8 for someone to qualify. Plus, we take into account other factors like mobility. Is someone able to stay at a healthy weight? A lot of other factors do play into that, but this is, we do have qualifying factors for that. Also, once someone, in the case of our philanthropic clients, once someone starts our meals, they can theoretically receive them indefinitely, as long as we get updated paperwork from them every year which is required by many of our funders. So that is also good. We have a lot of clients who've been on our meals for many years. Our second bucket of funding is Ryan White federal funding, which supports individuals living with HIV, AIDS, and hepatitis C. So that funding feeds those individuals specifically. And then our third and most quickly growing bucket of funding is through healthcare contracts. So we have contracts or partnerships with various insurance providers who will reimburse us for feeding their highest risk clients. We also provide support to home hospital programs, which are programs where hospitals to free up beds in the actual hospital will discharge patients to home with a very high level of care. And we provide the meals there. So it's almost as if they're getting the hospital meals, but they are at home. So we support a number of home hospital programs with that. And those tend to be pretty short term. And then finally, we partner with a number of accountable care organizations under the Mass Health System to provide meals to their highest risk clients. And this is notable. I know there's some folks in the room who are involved with what's called the Flexible Services Program right now, which was a bucket of money made available in 2020 to Mass Health to provide nutrition and housing supports for its highest risk members. And we have been lucky to be a part of that. And the thing that was a big switch for community servings with that piece of funding is that for the first time, we were really truly screening individuals for food insecurity as part of the Flexible Services Program. So in order to qualify to receive meals from us through that, someone had to screen positive for food insecurity, which was new for us. In January of 2025, the Flexible Services Program is going to be sunset, and it is going to transition to something called Health-Related Social Needs, or HRSN. And under that program, in order to qualify for meals, someone is going to have to screen positive for very low food security. So one step further, and I'll talk a little bit about how we are being asked to do that in a moment. Laura touched really nicely on food insecurity and what it is and what it means for people. And I actually really loved the way you explained it and talked about it. So I'm not going to read this to you, but I did want to at least mention food security and put this up here. And, talk a little bit about food insecurity, which is often associated with poverty, but also want to be very clear that there's a lot of other factors that leads someone to be food insecure. You can see the list here, and we see a lot of this here at Community Servings, individuals who are working but don't have enough money to provide food. I thought that statistic that you put up about household income and what you need to live in Suffolk County was startling and upsetting, actually. But you can see all of these factor into food insecurity. So the way we have screened up until now for food insecurity is using a tool called the 2-question Hunger Vital Signs Survey. And this is a validated tool that if someone answers one or both of these questions as often or sometimes true, they or their household are considered food insecure. So this is a really, it's a useful and I have found to be somewhat accurate tool. We take it at face value when speaking with individuals about this. And I think it's really hard to ask questions like this. Laura touched on that. It's sensitive and hard and people don't want to talk about this, but this is It's important for us to understand what someone's entire picture is when we're providing meals for them or their household.
What type of questions would those be? May I ask?
I'm sorry.
What type of questions would that be? What would be the type of questions that they would ask?
Well, so these are the two questions that are part of the survey
Okay.
that we ask. So this, either we're asking them or someone making a referral to us is that we're asking these questions to determine if someone is coming from a household that is experiencing food insecurity.
And are there point values, often, sometimes never, or?
No, this survey is if someone answers often or sometimes true to one or both of the questions, they are considered food insecure. So this is a pretty straightforward one to score. Moving forward, starting in 2025, Mass Health is going to ask us to use what is called the USDA 6-item short form food insecurity screening tool, which is a mouthful. These are the 6 questions that will be asked. And this survey tool needs to be coded and scored, and then based on a score, it determines if someone is positive for very low food security, or if their household is positive for very low food security. There are also 10 and 18 item versions of this that I suppose are more accurate. We are going to go with the 6-item question that also has a 12-month look back. You can use a shorter look back period for a lot of these surveys if you are speaking about a primary client who is really young and may not have actually been around for 12 months. So that is when you might alter that. Yes.
I may have missed it, but you were saying that this has to be coded or?
So each question has an answer that gets a value assigned to it, and then you code or you add it up, you average all of those, and then the score, there's a table that tells you where on the food insecurity scale someone lands.
Okay, thank you.
The whole, if you go, you can Google this, and also the link is in the resources. But if you Google it and look at it, the scoring system is on the document.
Thank you.
I want to just talk for a few minutes about health-related social needs as well. And, we talk a lot about food insecurity. I think about health-related social needs sort of as the next layer around that. And these are basic needs of life that when they are not in place or someone is lacking them, their health tends to struggle. So food insecurity is a key health-related social need. But it also includes housing, transportation, access to medications, and social support. So it's the whole picture of someone's ability to access the basic needs of life. And then sort of one more layer around that are what we call the social determinants of health. And this is the definition from the World Health Organization, and I don't need to read it to you, but these are the larger policy and social constructs that shape every society and everybody's access to the basic needs that they have. Social determinants of health are more impacted through advocacy and policy efforts, whereas health-related social needs in the work that we're doing and the food bank is doing, those are really more direct clinical interventions, like on the ground supports for people. But the social determinants of health shouldn't be lost on any of us, because that's really where you can drive greater policy changes. I think you showed almost the exact same piece of information, so I'm not going to spend a lot of time here. But food insecurity, or the impact of food insecurity on health outcomes, is really well documented in the literature. And Laura did a great job touching on this. But you see worsened physical health, health damaging behaviors, worsened mental health, and increased healthcare utilizations and costs when you see chronic food insecurity. This is just an example of what we see with individuals living with diabetes who are also experiencing food insecurity. It's worsened glycemic control, worsened diet quality, disordered eating patterns often, and poor self-management and increased risk for diabetes-related complications as a result of that. And also, this is the impacts of food insecurity on people living with HIV is really well documented as well. And you see many of the same health outcomes, including poor medication adherence. However, what you do see is that with improved diet quality, you see better outcomes with individuals living with HIV, better adherence to their ART therapy, better outcomes, better tolerance of the medications. This is a group of individuals that Community Servings has a long history of serving, and we all feel very passionate about. And we've seen a lot of great things with our clients living with HIV and AIDS through supporting them with our meals. This, again, Laura mentioned some of this. This is a chart that I keep handy because I find it really useful to remember what all the federal food insecurity programs are, what all the acronyms stand for, because I can never remember what they all are, and then specifically who they serve. So I wanted to put that in here in case it's helpful for anybody. I do really like this. We refer out to a lot of these programs when we can. We don't have as robust a system as the food bank for supporting individuals getting access to things like SNAP or WIC or other programs. We make a lot of referrals to Project Bread, where they do have a wonderful network of folks who can help others, to help our clients in particular access other benefits that they might need. I want to wrap up with by showing the food as medicine pyramid. For those of you who've never seen it, dietitians listening are very familiar with pyramids, but this is a little different in that it's meant to show sort of the progression of these overarching federal programs to provide support for food insecurity at a very broad level. And as you move up towards the tip of the pyramid, you start getting towards individuals with more severe illnesses that need more specific and tailored support. And that's really the context where medically tailored meals fall into place. So, at the bottom of the pyramid are like SNAP, WIC, HIP, and the other emergency food programs. And as you move up, you get more towards medically tailored food packages or grocery programs, and then medically tailored meals. Oops. I want to just mention some of our advocacy partners, because Community Servings doesn't just do medically tailored meals, although it is the most important thing that we do. We are involved with a lot of policy work and outreach work, and the goal of that is really to start to make programs like medically tailored meals universally available in the United States, so covered by health insurance where possible, and to give better access to everybody throughout the country. The Food as Medicine Accelerator is a really wonderful program that we're involved with, which is training other organizations throughout the United States, a lot of food banks, in fact, to start preparing and providing medically tailored meals to their communities, so we can, expand this kind of work to have a broader reach. We've done a lot of research over the last 10 years. Again, important with policy efforts, because if you want to change policy, you have to show that what you're doing is actually effective and making a difference. So we've done a lot of research. All of the citations for the peer-reviewed journal articles that we have out there are in the resources if you're interested in reading more. But a lot of great outcomes, and we actually currently have 3 NIH-funded research programs going on. We're looking at, one is called Food as Medicine for Diabetes, so we're looking at the impact of our meals on individuals living with diabetes combined with an intensive lifestyle intervention to see if we can help drive down individuals' A1C. Food as Medicine for HIV and diabetes, so same thing, but individuals living with HIV who also have diabetes. And then a third one called the Evaluation Consortium, which is examining the impacts of our medically tailored meals on certain healthcare outcomes and healthcare utilization. and actually, this is our newest study that just started recently. It's supported by the American Heart Association, and it's Food is Medicine for Families. So we're looking at the difference of providing medically tailored meals for individuals versus entire families. And also if there's a difference between supporting individuals by providing meals through a delivery driver versus a UPS shipment, which is something we've never looked at before. Our delivery drivers are the people who come in contact with our clients. All of the work we do otherwise is telephonic. So we never meet our clients in person, but our drivers do. And they, for many clients, provide a really important contact to the outside world. They are sometimes the only person our client will see during the week. So we're looking to see if that really makes a difference, and if expanding our ability to provide meals through our driver network is something that we should be working on too. And finally, if you want to get involved, I know some of you are staying here today and are going to volunteer with us, so thank you. You can go to our website and there is a way to sign up to be a volunteer at either location online. And we welcome volunteers at any time. It's a really fun experience. I hope those of you staying today have a blast. But we couldn't do the work that we do without our volunteer teams. We support, I think, 75 to 100 volunteers every single day. And our volunteers do things like help pack the bags of food or the boxes that go out, help cook our food, they help put it into the individual meal trays. They do everything and we couldn't do the work without them. That is all I have.
I really want to thank, health-centric advisors to really pull all this together. So with that, we thank you for joining us virtually. Hopefully you can join us in person next time. Thank you very much.